Hello everyone. In the previous lecture, we have discussed about the process of normal hematopoiesis. In this lecture, we are going to study about identifying the WBCs, and we'll also discuss about the quantitative disorders of white blood cells. Now, there are 5 types of white blood cells that we are going to find in the peripheral blood. The first one you can see here, it is a neutrophil. Neutrophil. Then we have eosinophil. Then basophil. Then monocyte. Then the lymphocyte. Okay. So basically, lymphocytes are they are originating from the lymphoid lineage. This we have discussed previously also, and the myeloid lineage will give the rest of the 4 types of cells. And among these 4, neutrophils, eosinophils, and basophils, these are known as the granulocytes because you can appreciate the granules in their cytoplasm. In monocytes and lymphocytes, you will not find any granules. Under normal conditions, you will not find any granules in monocytes and lymphocytes. Okay. Now, among these, neutrophils are the predominant cell types. These are the most common type of WBC that you are going to find in the peripheral blood of an adult. Okay, in adults, neutrophils are the predominant type of WBCs, but in children, lymphocytes are the predominant type of WBCs. Okay, so in children, lymphocytes are more, and in adults, neutrophils are more under normal circumstances. So, this constitutes around 40 to 75% of the total WBCs. The normal WBC count, you all know, that is 4 to 11,000 per microliter. 4 to 11,000 per microliter. Neutrophils are 40 to 75%. Lymphocytes are second most common, that is 20 to 40%. Third most common, monocytes 4 to 9%. Then eosinophils, that is around 1 to 6%. And basophils, that is around 0 to 1%. These are the least common type of WBCs. Neutrophils will have 2 to 4 nuclear lobes. How can you identify neutrophils? They will have 2 to 4 nuclear lobes, and these will be connected by these chromatin bridges. Okay, so these nuclear lobes will be connected by chromatin bridges. And in the cytoplasm, we will find various granules. These are known as primary and secondary granules. We will discuss more on this in a separate lecture. They can have primary or secondary granules. Primary granules are non-specific, otherwise known as the azurophilic granules. Secondary granules are specific. Okay, so as you can see here, this is a neutrophil. This is a neutrophil. You can see they have 3 to 4 nuclear lobes, and also they have granules in their cytoplasm. Again, this is a neutrophil. This is a neutrophil. Okay, so these are the neutrophils. Then we'll discuss about the eosinophils. Eosinophils are bilobed. These are bilobed. Okay, and they will have cytoplasmic granules, which are pinkish to reddish. So they will have pinkish to reddish cytoplasmic granules. These granules will contain various proteins like eosinophilic basic proteins. Okay, sorry, eosinophilic cationic proteins or major basic proteins. So these granules, they tend to bind to eosin dyes. Okay, so they will bind to the eosin dyes. That is why they will have this pinkish to reddish appearance, and that is also the reason for the name eosinophil. Okay, so these are the characteristics of eosinophils. In the peripheral smear, you can identify this is a eosinophil. You can see it has a bilobed nucleus and it has reddish cytoplasmic inclusions. Again, this is also a eosinophil. Then basophils have very dark. They will have purplish to dark blue stained granules. Purplish to dark blue stained granules. These granules will contain various substances like heparan sulfate, which are actually negatively charged, and they will tend to bind the basic dyes. Okay, so granule contents in basophils, they will tend to bind the basic dyes. That is why the name basophils, and they will produce this purplish to dark blue stained granules. And most of the times, these granules, they tend to overlap the nucleus. So in the peripheral smear, if you see a cell like this, which have a dark stained granules, which is overlapping the nucleus, which is present over the nucleus. then that is the basophil. So this is a basophil. Okay, and this is the least common type of WBC that we are going to find in the peripheral blood. Okay. Next one is the monocyte. Monocyte, you can remember these are the largest cells. I mean the largest type of WBC, something around 20 micrometer in diameter. They will have folded nucleus, and grace cytoplasm. Folded nucleus and grace cytoplasm. Of course, you will not appreciate any granules in monocytes. So you can see here, this is a monocyte. You can appreciate the folded nucleus, and you can see a grace cytoplasm. Last one is lymphocyte. Lymphocyte will have darkly stained, round to oval nucleus, darkly stained, round to oval nucleus, and very less cytoplasm. Cytoplasm will be very, very less. So as you can see, this is the lymphocyte. You can appreciate round to oval, darkly stained nucleus, and cytoplasm is very less. This is also a lymphocyte. So this is how you can identify the various WBCs in the peripheral blood. So neutrophils, these are the most common type of WBCs, 40 to 75%. They will have 2 to 4 nuclear lobes, which are connected by chromatin bridges, and they will contain the primary and secondary granules. Okay. Then you have the eosinophils. These are 1 to 6%. They will have a bilobe nucleus, and they will have pinkish to reddish granules. Basophils, 0 to 1%, least common. They will have purplish to dark blue stained granules, and these granules will overlap the nucleus. Monocytes, 4 to 9%. These are the largest cells. They will have a folded nucleus, They will have folded nucleus and a grace cytoplasm. Lymphocytes are 20 to 40%. They will have darkly stained round to oval nucleus and very less cytoplasm. So this is about the basics. Now we'll discuss the quantitative disorders involving various cells. First, we'll start with the lymphocytes. First one is lymphopenia. So how we define lymphopenia? So lymphopenia is defined as lymphopenia, we see the absolute lymphocyte count. Okay, so absolute lymphocyte count, if it is less than 1500 for microliter for adults, it is defined as lymphopenia, and for children it is less than 3000. Okay, the cutoff is more for children because, as I already told you, children will have more lymphocytes than any other WBCs. Okay, so that is why the cutoff is more for children. Lymphopenia can be due to various causes. It can be due to decreased production. Decreased production is seen in various congenital immunodeficiencies. You are going to find decreased production. We'll discuss this in detail under immunology section. Then redistribution of the lymphocytes is seen in various viral infections. So there are certain viral infections which can actually produce a substance that is known as type 1 interference. Okay, certain viral infections can produce type 1 interference. These type 1 interference can actually modify the lymphocytes. They can modify the lymphocytes. It can produce some of the adhesion molecules over the lymphocytes. That will cause migration of the lymphocytes to the endothelium. It will cause migration of the lymphocytes to the endothelium. And also it will cause sequestration of the lymphocytes in the lymph node. Okay, it will cause sequestration of the lymphocyte to the lymph nodes. This is known as redistribution, and this is also a cause for lymphopenia. Then there can be increased apoptosis of the lymphocytes, and this is done by the glucocorticoids. So basically, glucocorticoids cause increased apoptosis of the lymphocytes. That is why in patients who are getting steroids for various therapeutic reasons, they can have lymphopenia, and also the patients with Cushing's disease or Cushing syndrome, they will also have lymphopenia. Increased destruction of the lymphocytes can happen because of cytotoxic chemotherapy. radiation. And we have to remember that lymphocytes, these are the most sensitive blood cells. These are the most sensitive blood cells to radiation related injuries. Okay. So radiation can actually damage the lymphocytes much more compared to any other cells. And also HIV infection can cause lymphocyte destruction. Immune mediated destruction is classically seen in patients with systemic lupus erythematosus. It is classically seen in systemic lupus erythematosus. Okay, so these are the causes for lymphopenia. Now we'll see what are the causes for lymphocytosis. First of all, again, what is the definition? So again, we have to see the absolute lymphocyte count. If it is more than 5,000 per microliter in adults, that is lymphocytosis, and for children, again, it will have a higher cutoff, that is 8,000 per microliter. This is for children. Then what are the causes for lymphocytosis? Again, remember, there are certain viral infections which can cause lymphocytosis. We have discussed that some viral infections can cause lymphopenia because of increased redistribution. But certain viral infections can also cause increase in lymphocytes, and especially Epstein-Barr virus, cytomegalovirus, and certain viral hepatitis. These can actually increase the atypical lymphocytes. We'll discuss about atypical lymphocytes. This can actually increase the atypical lymphocytes and it can cause lymphocytosis. Okay. Epstein-Barr virus, classically it causes infectious mononucleosis. This I'll be discussing in a separate lecture. Okay. So Epstein-Barr virus, classically it can cause infectious mononucleosis. And in that condition, you are going to find atypical lymphocytosis, and that will ultimately produce the lymphocytosis. Okay. Now the next thing is certain certain bacterial infections like tuberculosis, brucellosis. Usually we associate bacterial infections with neutrophilia. I mean neutrophilic leukocytosis. But there are certain certain bacterial infections which can cause lymphocytosis. So classical tuberculosis, brucellosis, and a very important infection, that is Bordetella pertussis. Bordetella pertussis. This you must have studied in microbiology. Bordetella pertussis, which causes whooping cough. This actually produces a substance that is known as lymphocytosis promoting factor. Okay, lymphocytosis promoting factor. This lymphocytosis promoting factor can cause, actually it can inhibit the process of sequestration of lymphocytes into the lymph nodes. Okay. There are certain drugs like phenytoin, and tetracyclines. These drugs can also cause lymphocytosis. Graves' disease, I mean any condition with increased thyroid hormone activity, that can cause lymphocytosis. And neoplasm, like chronic lymphocytic leukemia. This is classical example of, classical neoplastic example which can cause lymphocytosis. Okay, so these are some of the important causes. Of course, there are various other causes, various other drugs, infections that can cause lymphocytosis, but these are the important ones. Okay. Now, I have told you in certain viral infections, especially the infectious mononucleosis, you are going to find reactive lymphocyte. You are going to find reactive lymphocyte. Now, how reactive lymphocyte is different from the normal lymphocyte? The normal lymphocyte we have already discussed. These are small. They'll have scant cytoplasm, no granules in the cytoplasm. Nucleus will be round. Sometimes it is indented. Most of the times it is round nucleus. And these are dark staining because they will have the condensed nuclear chromatin. In contrast to normal lymphocyte, in the reactive lymphocytes, you are going to find, this is a large cell. Okay, this is a large cell with increased cytoplasm. As you can see here, this is a large cell with increased cytoplasm. Reactive lymphocyte happens in response to certain antigens in various infections. Okay, these are large cells with increased cytoplasm. And they will have a large nucleus also with prominent nucleoli, And you can also appreciate that this nucleus has slightly opened up chromatin compared to the normal lymphocyte. Okay. And there is a phenomenon that is known as skirting. So what is skirting? Skirting means indentation of the cytoplasm of the reactive lymphocytes by the RBCs. So as you can see here, this is the RBC which is indenting the cytoplasm of the reactive lymphocyte. You can see here also. So this indentation produced by the surrounding RBCs upon this reactive lymphocyte, this is known as skirting. Okay. So indentation due to RBCs. Okay, this is known as skirting. Okay, and this is also a feature of reactive lymphocytes. Classically found in infectious mononucleosis, can also be found in toxoplasmosis, viral hepatitis, and phenytoin. Okay. So this is about the lymphocyte abnormalities. Now we'll see. Now we'll discuss about the neutrophil abnormalities, neutropenias, and neutrophilic leukocytosis. Okay, so let's start with the neutropenia. Neutropenia is defined as absolute neutrophil count of less than 1500 per microliter. Okay, absolute neutrophil count of less than 1500 per microliter. Then what is agranulocytosis? Agranulocytosis is nothing but a severe form of neutropenia. Okay, it is nothing but a severe form of neutropenia, which is associated with life-threatening infections. Usually, whenever you have severe neutropenia, that means absolute neutrophil count of less than 500, those patients will have increased risk of life-threatening infections. Okay, and that condition is known as agranulocytosis. Most of the times, agranulocytosis happens because of drugs, especially the cytotoxic chemotherapeutic drugs. Okay, so cytotoxic chemotherapeutic drugs, most of the times they will cause this agranulocytosis, and it will predispose to life-threatening infections. Okay, so what are the causes of neutropenia? So it can be divided into two groups. One is defective production. Okay, that means there is a defect inside the, some kind of defect in the bone marrow, maybe in the stem cells or maybe in the granulocyte progenitors, that can cause reduced production of the neutrophils. And also neutropenia can happen because of increased destruction or sequestration. So these things happen in the peripheral blood and decreased production. This here there is a defect inside the bone marrow. So as you all know, everything starts from the hematopoietic stem cells. It will give the precursor for the neutrophils. Those are nothing but the granulocytic precursors. And these neutrophils will come out of the blood. So if there is a defect in the hematopoietic stem cells, that can cause reduced neutrophil production. Defect in hematopoietic stem cells not only will cause reduction in the neutrophils, it will also cause reduction in all other lineage cells. So most of the times, hematopoietic stem cell damage will cause pancytopenia. Okay, so conditions like aplastic anemia, bone marrow infiltration, especially by the malignant cells, bone marrow infiltration by malignant cells or granulomas. Then cytotoxic drugs and ionizing radiation. So these are all the causes that will cause damage to the hematopoietic stem cells, causing subsequent reduction in the hematopoietic cells. Okay. Now there are certain conditions. There are certain drugs which can reduce the function of granulocyte precursors, which can damage the granulocyte precursors. These drugs include anticonvulsants, antibiotics, diuretics, and antipsychotics. There are various other drugs. Okay, I'm not writing all the drugs. There are so many drugs which can cause neutropenia, but these are some of the important examples. Some of the anticonvulsants, some of the antibiotics, diuretics, and antipsychotics, especially the chlorpromazine and phenothiazines. These are the antipsychotic drugs which are notorious to cause this agranulocytosis because they will damage the granulocyte precursors. Sometimes, whenever there is a defect in the DNA maturation, as we have discussed in the megaloblastic anemia, if there is a defect in the DNA maturation, it can cause destruction of the poorly formed, or you can say destruction of the abnormally formed neutrophils inside the bone marrow, and that is known as ineffective erythropoiesis. As I have told you previously, destruction of the precursor blood cells inside the bone marrow is known as ineffective erythropoiesis. So this can happen in patients with megaloblastic anemia, and this can also happen in patients with myelodysplastic syndrome. Again, we'll discuss this in a separate lecture. So in patients with megaloblastic anemia and myelodysplastic syndrome, because of some kind of abnormalities in these neutrophils, they will get destroyed inside the bone marrow itself, and that is known as ineffective erythropoiesis. Okay, and there are certain congenital neutropenias like Shwachman-Diamond syndrome, shortly known as SDS. Then there is something known as Postman syndrome. Okay. Postman syndrome is caused by ELAN gene mutation. ELAN is neutrophil elastase. Okay. So Postman syndrome is caused by ELAN gene mutation. And this is an example for congenital neutropenias. Okay. So these are the various causes which can cause decreased production of the neutrophils. Okay. And these are the mechanisms. Now we'll see neutropenia due to increased destruction or sequestration. Okay. First of all, we'll discuss what are the causes for immunological damage to the neutrophils. Okay. So these include SLE, systemic lupus erythematosus, rheumatoid arthritis. Actually, in rheumatoid arthritis, neutropenia can happen as a component of a syndrome that is known as Felty syndrome. Okay. So syndrome name is Felty syndrome. So Felty syndrome is classically described in patients with rheumatoid arthritis. It is characterized by a triad. The triad is rheumatoid arthritis with splenomegaly and neutropenia. Okay. Rheumatoid arthritis, splenomegaly, and neutropenia. So that is the triad for Felty syndrome. Okay. And it is associated with neutropenia. Okay. Then certain other immunological abnormalities like large granular lymphocytic leukemia, LGL leukemia. We have discussed about this. I mean, I have told you that previously, large granular lymphocytic leukemia can also be associated with pure red cell aplasia. Okay, so this LGL leukemia can also be associated with pure red cell aplasia, and this can also be associated with neutropenia. Okay, so if you see in the peripheral blood, you can appreciate actually this is a normal lymphocyte. Sorry, this is a normal lymphocyte, which is having a darkly stained nucleus and very thin cytoplasm. If you compare this with this lymphocyte, you can appreciate it has slightly more cytoplasm, and you can also appreciate some granules inside this cytoplasm. Okay, some granules inside the cytoplasm. So this is actually a large granular lymphocyte. Okay, so in the exam, if they give this peripheral smear picture, and along with that, they will give a history of either neutropenia or pure red cell aplasia, the answer has to be large granular lymphocytic leukemia. Okay. Then there are certain drugs like sulfonamides. Certain drugs like sulfonamides can also cause immunological damage to the neutrophils in the peripheral blood. Okay, this is the first mechanism. Second mechanism is increased margination of the neutrophils. So what do you mean by increased margination? So as you all must be knowing that neutrophils in the circulation, there are two forms of neutrophils. One form is which is present in the center of the blood vessel. As you can see here, these neutrophils are present in the center of the blood vessels. These are the circulating pool. Along with this, there will be some neutrophils which will be bound to the endothelium. These are known as the marginating pool. Okay, these neutrophils which are bound to the endothelium, these are known as the marginating pool of the neutrophils. Normally, when we check for the neutrophils in the peripheral blood, we only see the circulating pool of the neutrophils. The marginal pool of the neutrophils cannot be measured. Okay, the marginating pool of the neutrophils cannot be measured. Normally, we see only the circulating neutrophils. In certain conditions, this circulating pool of the neutrophils can go near the endothelium and they will become the part of marginating pool of the neutrophils. Okay, for example, this is classically found in gram-negative sepsis or gram-negative bacteremia. For example, E. coli infection. For example, E. coli infection. This will produce various endotoxins, and this endotoxin will actually cause margination of the circulating pool of the neutrophils. Okay, so that whenever you check for the neutrophils in the peripheral blood, when you do the complete blood count, you will have a reduced neutrophil count in the report. Okay, so because of this increased margination, these gram-negative infections are associated with neutropenia. Okay, but apart from this margination, infection in any other site, I mean infection due to other organisms like fungal organisms like rickettsial infections, all these infections can cause increased utilization of the neutrophils. As you all know, neutrophils help in tackling with the infections. So whenever there is an infection, these neutrophils from the circulation, they will tend to go to the site of the infection. Okay, so because they migrate to the site of the infection, the counts will reduce in the circulation. Okay, so in the blood, the neutrophil count will be reduced because all those neutrophils are engaged to tackle the infection at the site of the infection. So this can also be associated with neutropenia. This can also be associated with neutropenia. Okay, we always study that infections are associated with neutrophilia. Okay, but in certain situations, severe infections can be associated with neutropenia also. Okay, and this is the reason. Then the last one is splenomegaly. Whenever there is moderate to massive splenomegaly, there can be a phenomenon that is known as hypersplenism. In this situation, the spleen will take up all the blood cells from the circulation into itself. Okay, so neutrophils can be sequestered into the spleen whenever there is hypersplenism. That means increased activity of the spleen. Okay, increased activity of the spleen, it can pull up all the blood cells along with the blood. It can pull up everything into its into itself. Okay, so that can be associated with neutropenia. Not only neutropenia, usually hypersplenism is associated with pancytopenia. It is associated with pancytopenia. Okay, so these are the causes of increased destruction or sequestration of the neutrophils causing neutropenia. Okay, now we'll see what are the causes. Okay, before discussing about the neutrophilic leukocytosis, now let us discuss some of the morphological points.